Hello everyone. Today our topic of discussion is peripheral nerve disorders. The learning objectives are neuritis, neuralgia, neuropathies and GBS, that is known as Guillain-Barré syndrome. Starting with the definitions. What is neuritis? A neuritis is an inflammation of one or more nerves and it is caused by injury, infection or autoimmune diseases. Neuralgia is a symptom that is a sharp, shocking pain along the nerve pathway as a result of damage or irritation to that nerve. And neuropathy, it is a broader terminology which includes neuritis as its subtype. So neuropathy is an inflammation or degeneration of the nerves outside the brain or spinal cord and mainly affecting the peripheral nerves. It's a painful condition that is associated generally with nerve damage, dysfunction or degeneration rather than with inflammation alone. Before going into the detailed discussion about neuritis and other objectives, we need to learn about the normal structure of the peripheral nerve. So peripheral nerve is made up of primarily neuron and other supportive tissue. A neuron is the basic functional unit of the nervous system. It is primarily responsible for collecting information, processing and generating the response. A basic structure of the neuron includes a cell body or perikaryon, many short processes or dendrites which receive information from other neurons, and a single long process called axon which transmits signals to the other neurons. The dendrites and axons are collectively known as neuritis. So here we can see a diagrammatic picture of peripheral nerve. This one is the perikaryon and these are the dendrites which are the receiving ends of the information, and this long process is known as axon, and each axon is surrounded by the Schwann cells, and between these two Schwann cells the junction is known as node of Ranvier. A peripheral nerve is a collection of axons. It can be myelinated or unmyelinated with other supporting cells including Schwann cells and fibroblasts. A peripheral nerve consists of three distinct compartments, that is epineurium, perineurium and endoneurium. Epineurium is the outermost layer made up of fibroadipose connective tissue and also contains medium-sized blood vessels. The perineurium is the fibrous covering around a group of nerve fibers or axons and it forms the nerve fascicles. And endoneurium is the innermost compartment containing individual myelinated, large or intermediate size and unmyelinated nerve fibers or axons along with Schwann cells and fibroblasts. So in this diagram we can see the peripheral nerve containing three compartments. Outermost is epineurium, and within this epineurium we can see the different nerve fascicles. Each nerve fascicle is surrounded by the perineurium, and within this fascicle we can see an endoneurium containing nerve fibers, and each nerve fiber, that is myelinated axons, are also surrounded by the Schwann cells. This is the histopathological structure of peripheral nerve. We can see the outermost part, that is epineurium. These are the fascicles containing nerve bundles and blood vessels. Each fascicle is surrounded by the perineurium, and within the perineurium we can see the neurons, and neurons are surrounded by the endoneurium, and all endoneurium also contains the blood vessels. Here is the low and high power view of normal peripheral nerve, showing the three compartments: epineurium, perineurium and endoneurium. Endoneurium also contains blood vessels and other supportive tissue like Schwann cells and fibroblasts. Schwann cells perform the function of electrically insulating axons of the peripheral nervous system. Each Schwann cell will myelinate only one axon. The cell processes of the Schwann cell wrap around an axon in multiple layers and forms the myelin sheath. A large diameter axons are always myelinated, while small diameter axons can be myelinated or unmyelinated. A Schwann cell also performs an important role in nerve regeneration after injury. Here is the ultrastructural picture of peripheral nerve showing a large myelinated axon, and it is surrounded by the Schwann cell. These are the unmyelinated axons surrounded by the Schwann cell, and this is known as Remark cell. Myelinated axons are thicker and surrounded by chains of Schwann cells which produce myelin sheath. Non-myelinated axons are having diameter of 0.2 to 3 micron, and about 10 non-myelinated fibers may be enclosed by Schwann cells. A nodes of the Ranvier or myelinated fibers are the boundaries between each Schwann cells surrounding the fiber. Now, neuritis. As we have discussed, neuritis is an inflammation of the nerve. Whenever it affects only one nerve, it is known as mononeuritis, and whenever the whole plexus of the nerve get inflamed, it is known as plexitis. Mononeuritis multiplex is called when there is several single nerves are affected simultaneously, and whenever a widely separated nerves are affected, it is known as polyneuritis. The symptoms of neuritis are usually confined to a specific portion of the body served by the inflamed nerve or nerves. The causes of the neuritis includes autoimmune diseases like multiple sclerosis, infection either bacterial such as leprosy or viral like a varicella zoster, post-infectious immune reactions like Guillain-Barré syndrome, or a response to a physical injury as frequently seen in sciatica. Clinical features of neuritis will depend upon which type of neurons are inflamed. So whenever sensory neurons are inflamed, there will be a tingling, burning or stabbing pains that usually become worse at night and aggravated by touch or temperature changes. Whenever motor neurons are inflamed, there will be a muscle weakness and paralysis, and muscles in the area served by the affected nerve will lose tone, they will become tender and may atrophy. A Bell's palsy, which causes a characteristic distortion of the muscle on one side of the face, is a form of mononeuritis, and it is caused by inflammation of the facial nerve. The condition is also known as a form of mononeuropathy. Diagnosis of the neuritis will include physical examination to characterize and localize any symptoms to a specific nerve or distribution of the nerve. Blood tests are helpful to evaluate blood glucose and serum B12 levels with metabolites, additional measurement of specific vitamins or toxins, and other medical tests like nerve biopsy, MRI, electromyography, nerve conduction studies, fundoscopy, and lumbar punctures are also helpful. Treatment of neuritis will include removal or management of any inciting cause of inflammation, followed by supportive care and anti-inflammatory or immune modulatory treatment, as well as symptomatic management. Neuralgia. A neuralgia is a sharp, shocking pain that follows the path of the nerve and is due to the irritation or damage to the nerve. So generally, neuralgia isn't an illness, but actually it is a symptom of injury or a particular disorder, and it is more common in older people but can occur in any age. Common neuralgia includes post-herpetic neuralgia and trigeminal neuralgia. Other are the neuralgia resulting from alcoholic neuropathy and peripheral neuropathy. Causes of neuralgia includes chemical irritation, diabetes, infections like herpes zoster, shingles, HIV/AIDS, Lyme disease, and syphilis. Medicines such as cisplatin, paclitaxel, or vincristine, porphyria, one type of blood disorders, pressure on nerves by nearby bones, ligaments, blood vessels, or tumors, trauma including surgery. The post-herpetic neuralgia and trigeminal neuralgia are the two most common forms of neuralgia. A related but less common neuralgia affecting glossopharyngeal nerve can also result in glossopharyngeal neuralgia. Trigeminal neuralgia is also known as tic douloureux. There is a brief attacks of severe pain along the trigeminal nerve, It can occur at any age after puberty, but most commonly affects the person over 50 years of age. Women are more frequently affected. There is an intense stabbing pain felt in the jaw or cheek. Areas around the nose and mouth become hypersensitive, and when touched, they can trigger an attack. Attacks may also be caused by talking, eating, drinking, or exposure to cold. Anticonvulsant medications are useful to treat trigeminal neuralgia. Analgesics can also give a temporary relief. If medications fail to relieve, a surgical management in form of decompression or severing the sensory root of the trigeminal nerve will be helpful. To diagnose neuralgia, there is no specific test. Diagnosis relies more on ruling out other possible causes for the pain. Neurological examination is done to determine specific areas of pain. Dental examination is done to check for abscesses that may be irritating nearby nerves. Blood tests to check for infection, and X-rays and other radiological tests to see if the affected nerves are being compressed or not. Treatment of neuralgia will include the treatment for underlying cause, such as dental treatment and antibiotics for a tooth abscess, or surgery to remove bone pressing against the nerve, pain relieving medication such as aspirins or codeine, anticonvulsant medication to treat the pain and muscle spasm associated with trigeminal neuralgia, antidepressant drugs to help relieve pain in some cases, surgery to desensitize the nerve and block pain messages, physical therapy such as physiotherapy and osteopathy. Alternative therapies such as acupuncture, hypnosis, and meditation are also useful. Neuropathy. A peripheral neuropathy is a disorder of the peripheral nerves of any cause. Polyneuropathy is term used for symmetrical with noticeable sensory features such as tingling, pricking, burning sensation, or dysesthesias in feet and toes. Motor features in the form of muscle weakness and loss of tendon reflexes may be present. Mononeuropathy multiplex multifocal neuropathy is simultaneous or sequential multifocal involvement of nerve trunks which are not in continuity. Multifocal neuropathy represents part of spectrum of chronic acquired demyelinating neuropathy. Mononeuropathy is focal involvement of a single nerve, and it is generally the result of local causes such as direct trauma, compression, and entrapment. Causes of neuropathy include inherited causes like hereditary sensory and autonomic neuropathy, hereditary motor and sensory neuropathy, congenital demyelinating neuropathy, giant axonal neuropathy, Repsum disease, hereditary amyloidosis, leukodystrophies, and porphyria. Metabolic causes like diabetes mellitus, various vitamin deficiencies, uremia, hypothyroidism, and acromegaly are also causing neuropathy. Toxic causes like alcohol intoxication, lead, drugs, and critical illness neuromyopathy. Inflammatory causes will include Guillain-Barré syndrome, chronic inflammatory demyelinating polyradicular neuropathy, vasculitis, sarcoidosis. Infective causes like leprosy, HIV infection, Lyme disease, cytomegalovirus, and diphtheria are also responsible for development of neuropathy. And certain neoplastic or paraneoplastic conditions, primary light chain associated amyloidosis, and paraproteinemic neuropathy are responsible for the neuropathy development. The three main types of degenerative processes can develop as a response to a pathological reactions of peripheral nervous system. So common is the Wallerian degeneration. After transaction of the axon, it may be result of a knife wound, compression, traction, and ischemia. Following transaction, initially accumulation of organelles in the proximal and distal ends of the transaction site. Subsequently, the axon and myelin sheath distal to the transaction site undergo disintegration up to the next node of Ranvier, followed by phagocytosis. Axonal degeneration is degeneration of the axon beginning at the peripheral terminal and proceeds backwards toward the nerve cell body. The cell body often undergoes chromatolysis, and there will be a Schwann cell proliferation in the region of axonal degeneration. Segmental demyelination It is similar to demyelination within the brain. Segmental demyelination is a loss of myelin of the segment between two consecutive nodes of Ranvier, leaving a denuded axon segment, and this may show regeneration. The axon, however, remains intact. Repeated episodes of demyelination and remyelination results in the formation of concentric rings that resembles onion bulbs. Traumatic neuroma. Normally, the injured axon of a peripheral nerve regenerates at the rate of approximately 1 mm per day. However, if the process of regeneration is hampered due to an interposed hematoma or fibrous scar, the axonal sprouts together with Schwann cells and fibroblasts to form a peripheral mass called as traumatic or stump neuroma. So here is a toluidine blue stain showing histopathological structures of chronic axonal neuropathy. The regenerating clusters, these are the regenerating clusters along with the occasional acutely degenerating fiber. Here is the onion bulb appearance, a chronic demyelinating neuropathy. There is a formation of onion bulbs which is composed of concentrically arranged Schwann cells surrounding a central axon, and it is partly covered by a thin myelin. Peripheral neuropathy can also be classified according to number and distribution of the nerves affected in form of mononeuropathy, mononeuritis multiplex or polyneuropathy, type of nerve cell affected, motor, sensory and autonomic, or the process affecting the nerve. For example, inflammation, compression, chemotherapy. The symptoms of neuropathy will include motor symptoms like weakness and atrophy, sensory loss in form of whenever large fibers are affected, there will be loss of position sense, and whenever the small fibers are affected, there will be a loss of pain or sometimes pain appearance, reflex loss, autonomic symptoms in the form of redness and dizziness. So sensory symptoms are a sensation of wearing an invisible glow or stocking, numbness, pins and needle sensation, feeling of walking on pebbles, feeling of tightness and swelling, burning sensation or freezing pain, sharp jabbing or electric shock like pain, extreme sensitivity to the touch, usually become worse at night, loss of balance and coordination, and there can be a cramps in the feet and calves. Motor symptoms include tripping on the toes, loss of grip strength, and ankle jerk reflex is classically absent in peripheral neuropathy. Signs of neuropathy will include weakness, that is usually distal and symmetrical in polyneuropathy, muscle atrophy, there will be a loss of muscle bulk, reduced tone and flaccidity, sensory deficit varies with somatotropic distribution, and areflexia, that is loss of reflexes in lower motor neuron lesions, while hyperreflexia in upper motor neuron lesions. There are various classifications available for grading of the neuropathy, but one of the common classification used is Sunderland classification, ranging from type 1 to type 5, and conduction block, there is neuropraxia, axonotmesis and neurotmesis are different grades of neuropathy. One specific type and common neuropathy is diabetic neuropathy, occurring in patients of chronic diabetic condition. So here is the healthy tissue. So whenever there is a diabetes related metabolic or vascular condition, it can cause a capillary damage. A capillary damage can lead to a nerve damage and loss of sensation, especially in the extremities. There will be injury due to loss of sensation, and there can be a loss of sensation and circulation problem resulting in increased risk of infection, ulcers and gangrene. Investigations of the neuropathy includes blood examination, that will include total count, differential WBC count and ESR estimation, serum estimations like urea, electrolytes and liver function test, routine blood sugars and HbA1c to rule out the metabolic disorders, serum protein electrophoresis, autoantibodies like ANA, anti-gangliosides and anti-neuronal antibodies level assessment, vitamin B12 level assessment, DNA analysis for various chromosome 17 duplications. Urine examination will include Benz-Jones protein, porphyria and heavy metal analysis. CSF analysis can also be helpful. Nerve conduction studies including variation in axonal demyelinating neuropathy, conduction block in Guillain-Barré syndrome, electromyography for looking for muscle denervation changes, and sensory threshold measurement. Radiological imaging will include chest X-ray to see for sarcoidosis and malignancy, skeletal survey to look for multiple myeloma and screening for malignancy. Autonomic function tests are also useful, and diagnostic tests are very much important in asymmetric motor predominant rapid onset demyelinating neuropathy. The nerve conduction studies evaluates how the nerves transmit the electrical stimuli. Electromyography measures the electrical activity of muscles in response to a nerve stimulation. A skin biopsy, a small fiber neuropathy cannot be diagnosed with electromyography, and nerve conduction studies that only measures the large fibers. So this skin biopsy may helpful. Autonomic test, the quantitative pseudomotor axon reflex test, measures the autonomic nerve fibers that stimulate sweating. This is a tilt table test which measures your changes in blood pressure and pulse from prone to vertical position, and also detects autonomic nerve involvement. And nerve biopsy provides tissue for pathological examination. It will show if vasculitis or inflammation of the blood vessel as well as demyelination that is missed by electrodiagnostic studies. Vasculitis can decrease the oxygen supply to the peripheral nerve and will quickly cause damage to the nerve tissue. So traditionally for nerve biopsy, a sample from sural, subperoneal and supraradial nerve is taken, and various conditions like vasculitis, amyloidosis, sarcoidosis, leprosy, Krebs disease, giant axonal neuropathy, infantile neuroaxonal dystrophy can be diagnosed with this nerve biopsy examination. Now in brief about the Guillain-Barré syndrome, it is an acute or subacute progressive polyneuropathy that may follow a non-specific upper respiratory or gastrointestinal infection, for example cytomegalovirus, Campylobacter jejuni, EBV, Mycoplasma pneumonia and HIV virus, vaccination, pregnancy or surgery. There will be a paresthesia followed by weakness, but variants includes pure motor or sensory syndromes. There can be autonomic dysfunction and the Miller-Fisher syndrome development, which includes ataxia, areflexia and ophthalmoplegia. Neurophysiology study will show a slowed nerve conduction. There will be CSF protein elevation. In most cases, a nerve biopsy is not indicated. There is a patchy foci of segmental demyelination, endoneurial edema and a patchy inflammation can be seen if biopsy is carried out. A pathognomonic but uncommonly seen feature is macrophage-induced stripping of myelin sheaths, which can be seen at electron microscopy. The predominantly axonal form, acute motor axonal neuropathy, acute motor and sensory axonal neuropathy have a worse diagnosis, and they are often associated with the Campylobacter jejuni infection. So this includes our discussion regarding neuritis, neuralgia and neuropathies. Thank you.